most medical students, they have a table like this in their notes. And let's say if this is a table, very badly drawn table, but let's say this is a table and they have got the nerves, ulnar, radial, musculocutaneous, and on the right side of the table they write down the effects of nerve palsies and nerve injuries. And it seems to be very easy, they memorize it again and again, seems to be very easy. But when it comes to the actual exam, whether that exam be USMLE or NEET PG, they always fumble up and they always confuse which one is which. So today we are not going to make any table today. We are going to study upper limb nerve injuries with the help of a simple pattern. And with this lecture, hopefully you don't confuse in your exam when this topic shows up. So what I am going to do is I am going to start my discussion by drawing a bone, a simple bone. And guess which bone is this? Bone is the arm bone, the humerus. So this is the arm bone, the humerus, ARM. Now, if there is a fracture of humerus at this point, exact point I'll tell you, but at this point, remember A. If there's a fracture over here, remember R. If there's a fracture over here, remember M. So arm is the mnemonic, the first mnemonic of this class, and hopefully only mnemonic of this class. I'm not a big fan of mnemonics to say, but A stands for axillary nerve, which means if there's a fracture at this point, axillary nerve is going to get damaged. R stands for radial nerve, which means if there's a fracture over here, radial nerve is going to get damaged. M stands for median. M stands for median. So it means if there's a fracture over here, median nerve is going to get damaged. What are those exact sites? Let me write it down for you. The exact sites will be if there is fracture of surgical neck of humerus, the nerve damage is going to be axillary, as you can see from the diagram. And if there is a fracture and the mid shaft, the nerve damage is going to be radial. If there is a fracture of the supracondylar region, okay, over here, so there is going to be median nerve damage or median nerve injury. So that was the simplest thing. What we will now do is we will pick this nerve. We'll start by picking the axillary nerve and discuss it in more detail. So one thing about the axillary nerve is that it winds around the humerus. If this is the humerus, what the axillary nerve does is it winds around the humerus. So here's a diagram of it, that you can really see the nerve going around and circling the humerus, specifically the neck of the humerus. Now, what are the conditions when the axillary nerve get damaged? You will say, sir, you already told it that the nerve gets damaged with fracture of humerus, surgical neck of the humerus, but there is also another condition, which is dislocation of humerus also causes the damage to axillary nerve. Now, what will happen if there is damage to axillary nerve? We first need to understand what the axillary nerve supplies to. So the axillary nerve supplies the deltoid, it supplies the teres minor, and it supplies the skin over the lateral shoulder. This is going to be sensory. So obviously we'll start the effects of axillary nerve injury with the loss of sensation over the lateral aspect of shoulder. Then there is going to be a flattened deltoid, which is flat in appearance, has lost its circularity, and loss of abduction. This is very important, loss of abduction, because examiners like to test on this. Loss of abduction over or after, loss of abduction after 15 degrees. So why 15 degrees? Because abduction till 15 degrees is done by the supraspinatus, and abduction after 15 degrees is done by the deltoid. So that is why abduction is lost after 15 degrees. The patient patient can do a little bit of abduction, but not complete abduction. Now we will discuss the musculocutaneous nerve. Now you need to remember the musculocutaneous nerve as if it's like the main nerve of the arm. It's coming from the brachial plexus, going traveling down like this, and it's going to the forearm, and it supplies the major muscles of arm, and it supplies the flexors of the forearm. So injury is going to be by if the upper trunk of brachial plexus gets injured, and whenever there is injury, there's going to be weak supination and weak forearm flexion. Along with weak forearm flexion, there is going to be loss of sensation from the lateral aspect of the forearm, because musculocutaneous nerve has sensory supply in this region. So these are the effects. Now let's move on further to radial nerve. Now if musculocutaneous nerve was the nerve of the flexors, radial nerve is, let's say, the nerve of the extensors, generally speaking. So obviously radial nerve damage or injury is going to cause what we remember, the famous wrist drop. And along with wrist drop, there's going to be weakness of any movement of the extensors, because the radial nerve supplies the extensors. So it supplies the extensors of the arm, forearm, fingers. So weakness in movements like gripping if there is injury of the radial nerve. And one thing is that with radial nerve injury, there is no major sensory loss. So injury of radial nerve can be at three different levels. First level is at the level of the axilla, compression of the axilla. Let's say the person is using crutches. Then, or at the level of midshaft of the humerus. I already told you this. Midshaft humerus fracture is going to cause radial nerve damage. Or there's a branch of a radial nerve called as posterior interosseous nerve, and if there is injury to this posterior interosseous nerve, there is going to be finger drop. And if there is midshaft fracture of the humerus, always remember that the triceps are spared, because the supply to triceps happened before the midshaft. So if there's a fracture of here, triceps are usually spared, and triceps are not spared if there is any injury to the level of the axilla, like if the person is using crutches, or there is the famous Saturday night palsy also comes over here, where the person sleeps on a armchair and his axilla is compressed. Now let us discuss the median nerve. This diagram is going to be really helpful in knowing the supplies of various nerves. So median nerve supplies this region of the hand, and which is the nervous sensory supply. So the median nerves give sensory supply to this region of the hand, and ulnar over here, radial of this. Remember this diagram, this is given in all the major textbooks. It's also given in your first aid, and this is a must read, something which you should quickly go through before exams. Coming to the motor functions or the motor innervations of the median nerve, it causes forearm pronation, wrist or finger flexion on lateral side, and it also supplies to the thenar muscles. Now in cases of median nerve injury, the injury can be at a proximal level or at a distal level. So if the injury is at a proximal level, that injury is, I am talking about this injury which I told in the first starting of the video itself, the supracondylar fracture of the humerus. And now we are entering a very high yield territory, because this gets really tested and students confuse over here. So in cases of proximal median nerve injury, there is the hand of benediction, because median nerve supplies the index and the middle fingers, whereas if there is distal median nerve injury, which is over here. So proximal is over here and distal is over here. You get your carpal tunnel syndrome. And you also get median nerve injury when there is a wrist laceration, and this causes the famous ape hand. So this is where students get confused in between. Hand of benediction is when there is proximal median nerve injury, and ape hand is when there is medial nerve injury. So this is high yield. And ape's hand, there is going to be weakening of the thenar muscles. Ape's hand, there's going to be weakening of the thenar muscles. Remember this. Now we're going to discuss the ulnar nerve. Now, if you go and scroll and see this picture, you already know which sensory supply will be lost. There's going to be loss of sensation over here if there's ulnar nerve injury. Really, this diagram is really high yield, man. It's given in all the textbooks and it's given in first aid, so you cannot spare to forget this. Now, coming to the motor supply, it supplies the muscles of the hand, this muscles which I am talking about, ulnar nerve, let's say. And if there is a injury, there are three ways in which you can really injure your ulnar nerve. So three possibilities or three sites of injury, they are your first is at the medial epicondylar fracture. Okay, this is going to be the first scenario. The second scenario, from the epicondylar fracture to over here, the fracture of the hook of hamate. Over here, the fracture of hook of hamate. That's going to be the second scenario. I told there are going to be three scenarios. The third scenario is when there is a cyclist handlebar compression, not a fracture but cyclist handle compression. Now this causes the famous handlebar palsy. Finally, the last nerve, recurrent branch of median nerve. This needs a separate discussion in itself. Recurrent branch of median nerve, because of some features which are unique to this. And the most unique thing and the high yield thing which examiner like to test is, again I'm saying it's really high yield, that it is motor only. It has not any sensory supply. So, and its motor supply is to the thenar muscles, and injury is by the laceration of palm. So whenever the question stem gives you this, that there is a classic question that the patient has a laceration of the palm, and after this injury he has a weakness of the thenar muscles but no sensory loss. Now this no sensory loss is going to be the biggest clue of choosing your answer as the recurrent branch of medial nerve. So we'll do the rapid revision of all these nerves. If there is axillary nerve damage, there is going to be shoulder abduction problem. Shoulder abduction. If there is musculocutaneous nerve injury, there is going to be a problem with your biceps or supination problem. If there is radial nerve injury, there's going to be a problem with your wrist. If there's going to be median nerve injury, you get your hand of benediction. You get your hand of benediction or the hand of ape hand. Finally, if there is ulnar nerve injury, you get your claw hand, which is the ulnar claw. So that was the rapid revision of all these upper limb nerve injuries. These are very high yield. They do come, and I always tell students to read them in the very last moment. If there are any more topics which you find confusing, you can mention in the comments. I'll try to make a video on them as well. All right, till then, take care. Bye. Happy studying.